I would highly recommend going back through and looking at your Canvas page under the infection section, down at the bottom where it says after class. It's got a bunch of different boxes and tables and stuff that are listed. And so that's gonna be kind of throughout the lecture. May not necessarily say the page number in the box for that slide, but all of those boxes and tables pertain to the lecture today. I'll give you a heads up as best I can, but I may skip one or two. But make sure you go back through and see what's listed after the class section. All the boxes and tables and stuff are listed for us. Okay. All right, Natalie, I'm fixing to start recording.
Oh, I already know what's lost, so.
Alright, so today we're gonna talk about infection. And it's really a lot of different disease processes thrown into this infection lecture. We kind of lumped them all together. So there's 7 different ones. And I classify them into really body systems. So I know it just kind of sounds all over the place. But for conjunctivitis and otitis media, that's gonna be your ear, nose, and throat system. You got your influenza, pneumonia, and your tuberculosis. That's gonna be more of your respiratory type disease processes. And then UTI and osteomyelitis are kind of your eyeballs there. So UTI, you put under reproductive, you could put it under your urination, and then osteomyelitis is just kind of that eyeball as well. So, and that's how we're going to classify them. First off, we're going to start with conjunctivitis. So conjunctivitis, also known as pink eye, more common, and that's what most people are going to say. I've got pink eye, got some redness in my eye. It's really just the inflammation or infection of that conjunctiva of the eye. We're gonna look at a picture of the structures of the eye so we understand what the conjunctiva actually is. We're gonna classify conjunctivitis into 3 different categories, and those categories are gonna be typed based on the symptom presentation. And so that's how we're gonna classify our conjunctivitis, and that's gonna be really important going forward. So for this picture, I really want you to understand that the conjunctiva encapsulates the entire eye. It's not the white part of the eye, that's your sclera. It's not the colorful part of your eye, that's your iris. It's the clear film around the entire part of the eye that encapsulates it, closes it around that eye. That's what's inflamed, that's what's infected when we're talking about conjunctivitis. I like this slide, this is a great slide. Just throwing that out there. So, like I said, when we're classifying our types, these first 2 bullet points here are really key. It's usually going to present bilaterally, and that's how we're going to kind of distinguish it from our viral conjunctivitis. It's going to be in both eyes typically. It may present in one eye initially, but eventually it's going to cross over and become infected in that other eye as well. We're also gonna have that thick, purulent, nasty, gross, disgusting, however you wanna describe it, discharge. Your patients are gonna complain that it's hard to open up their eyes first thing in the morning. They just have this matted, just gross, thick, green, yellowy discharge. That's how they're gonna describe their discharge when they're bacterial conjunctivitis. Usually you're gonna be in your school-age children, that's when it's most prevalent in. When we go to our viral conjunctivitis, then we're gonna start to see kind of the older children and the young adults. That's what we're gonna see the most cases in. Our difference with viral conjunctivitis, usually it's unilateral in nature. 9 times out of 10, it's gonna be just present in one eye. Now that doesn't mean it can move over to the other eye as well. Yes, it can, but usually it's gonna be unilateral. The key difference here with the discharge is watery and clear. So we're no longer talking about that thick, purulent drainage, the green, gross type drainage. It's more of just a watery, clear type drainage. Almost kind of just like they're crying, for instance. So it's kind of hard to distinguish if it's discharge or just maybe they're upset or something like that. Then we have a 3rd category, which is gonna be our allergic conjunctivitis. Key points with our allergic conjunctivitis is going to be the on and off of our symptoms. All right, what do y'all think that means? on and off of symptoms. What could that represent? Seasons, I like it. Triggers, what else you said, John? Exposure, good. All those are good points. So when we come into contact with an allergen or some kind of irritant, some kind of pathogen, something is going to irritate that eye and kind of stimulate that allergic response that we have with that eye. And that's what's gonna cause that redness, that irritation, the itchiness, a little bit of watery, stringy discharge that we may see. Once we kind of remove that stimulus, we remove that irritant, we're removed from that exposure, then our symptoms will go away on their own. And then if we come back in contact with it again, it's kind of just a repetitive cycle of symptoms being present and then symptoms going away. Does that make sense for everybody? Okay. So that's our three distinct types of conjunctivitis. These pictures right here are really great to kind of see side by side, and so you can get kind of that visualized picture of your bacterial versus your viral conjunctivitis. Usually that's what we're trying to distinguish between the two. Is it viral or is it bacterial? We usually know if it's allergic because once we get away from that irritant, then the symptoms go away. So now we have to further break it down, is it bacterial versus that viral? So as you see again with your bacterial conjunctivitis, we have some of that thick purulent drainage, it's kind of yellowy, it's sticky. We have a little bit of drainage on this side right over here. It's really hard for them to open that eye. Versus on the viral side, we just kind of have that red, inflamed look to it, that irritated look to it. We notice it's a little bit of clear, watery discharge, but it's a lot different than that bacterial conjunctivitis as well. I included another slide as well, so it's kind of important, don't y'all think, to know the signs and symptoms of your three different types, right? So again, you have your bacterial, your viral, and your allergic. Your allergic and your viral conjunctivitis are gonna look very similar in presentation. So that key feature is gonna be the on and off of those symptoms. So conjunctivitis is gonna be self-limiting. So it's gonna go away on its own eventually. Very rarely will it continue to progress and get more serious with symptoms. So it's self-limiting. It's gonna usually run a course of 5 to 7 days, and then your symptoms should start to improve. The discharge will start to decrease. You may not have discharge at all. But if the symptoms progress or get worse, then we may have to start some type of treatment. Of course, the treatment is gonna go with what stage or what type of conjunctivitis we have. So we have for bacterial conjunctivitis, what are we gonna be putting on? Antibiotics, that makes sense, right? Because it's bacterial in nature. We can't put antibiotics on a viral type illness, not gonna work. So for bacterial, common examples are gonna be your ciprofloxacin or your ofloxacin. Anybody know what category that's in? How about fluoroquinolone, does that sound good? Yes, that sounds good to me, all right, perfect. All right. Are these gonna be, yes?
I'm sorry, unrelated, can we turn the lights down a little bit, it's harder to see the screen.
Yes. If I can figure out the right button over here, though. That's all one of them. The better?
Yeah.
Which one?
You slip the buttons to find it? Yeah, that's way better.
Is that better?
Yes.
Movie night.
Setting the mood, I like it. Setting the mood for infection. Just stay awake, please don't fall asleep.
Yeah, y'all gotta stay awake.
All right, so for viral, we're gonna move on a little bit further. Viral conjunctivitis. If we need treatment for that, we're gonna start them on some type of antiviral. If we remember, our antivirals end with VIR, right? The VIR. So your cyclovirs. That can be key to help with hopefully identifying your antiviral class. And then with allergic conjunctivitis, it's pretty simple. Remove what's ever affecting the eye. Whatever that irritant is, whatever that allergen is, remove it. symptoms should get better. But we can also see some supportive care as well, so artificial tears, maybe some Visine, things like that, just to hopefully calm down, moisten that eye, hopefully reduce some of that itchiness, that redness, things like that. Well, questions? Are these going to be oral antibiotics or oral antivirals?
No, should be topics
Topicals?
in the eye.
So like just a cream?
No, eye drops.
Eye drops? Eye drops. Alright, so intraocular eye drops. Makes the most sense, right? It's affecting the eye, so we probably don't need oral antibiotics. We need eye drops to go directly in the eye. Alright, so what do we need to educate our patients on for conjunctivitis? Your number one question, when can my child return to school? That's pretty common most of the time. Or when can I turn to work? No one really asked that, but when can I return to school? They're gonna tell them 24 hours after their antibiotics or their antivirals and they're fever-free, they're no longer contagious. That's when they can return to school. Reduce the spread of infection. Your viral conjunctivitis is gonna be more of your highly contagious type of conjunctivitis. So how are we gonna reduce that spread, just in general, of conjunctivitis? Hand washing? Okay, what else?
Yeah, keep your hands out of your eyes.
Keep your hands out of your eyes, I like that. What else?
Washing your hands.
Washing hands, we already said that, but good.
Oh,
Good
sorry.
try again.
Clean your glasses.
Clean your glasses, good, I'm glad you brought up glasses. Can we wear contacts?
No, you shouldn't.
No, so we need to throw away those contacts that we had while we were, got that infection, we developed that infection. We can wear our glasses until our symptoms have improved, until that infection has cleared. Then we need to sterilize our glasses, clean our glasses as well. Get a new pair of contacts after our eye infection has cleared. Other things, what about towel use, bed sheets, things like that? Need to wash frequently. Don't allow the other child in the house to use the same towel or allow them to sleep together in the same bed. All that discharge and stuff on those pillows, it could cross-contaminate and you have your other child sick and then you have the whole household with pink eye. What about females when you put on the black paint on your eyes? Mascara, there you go. The black paint on your eyes. That's right, directly contacting that infection site, right? So probably need to get rid of that mascara and grab a new brand of whatever you like. The,
Eyeliner?
that's the colored paint.
Yes.
Okay.
This is the stick.
The colored paint, need to throw that away as well. Might even have to get rid of just the regular base paint. So just start over with your makeup. But it's not also just the makeup, it's the brushes as well. We need to get rid of it all and kind of start back over. Alright, so get some elf brushes and Clinique makeup. I know these things.
Eye paint.
Yeah. Medication administration. How are we going to educate our patients about the eye drops? Have you got any thoughts?
Depends on how many, like.
Show them how to put them in.
How to put them in, all right? Are we gonna directly touch the eyeball itself? No, we need to try to avoid that as much as possible. And so we're not recontaminating every single day when we give those antibiotic eye drops.
Time in between eye meds.
There you go, good.
You know, like hold your head back, open it,
Yep.
but looking upwards.
Yes, you can do that. Our children are gonna want eye drops in general.
No, that just holds them down.
Hold them out.
Sure.
I've had to.
Two-person job. It can be a two-person job. Last thing that I wanna mention, with your viral conjunctivitis that I skipped over. We can get what's called chlamydial conjunctivitis as well, which is a type of viral infection, that you can pick up through sexual intercourse. How it gets in the eye, I'm gonna let you use your imagination on that. But if we see it in children or older children, that could be a sign of sexual abuse. So I just wanna put that in the back of your mind. can be pretty uncommon, but just in the back of your mind, we're not gonna test everybody for that, but just in the back of your mind, we're gonna think about sexual abuse. Okay? There's your questions, Sam.
Why do you do that to me?
Sam Thorne, changing up so you don't
Okay,
answer
I still
questions
wanna get it.
before that time.
Give me a second to read it.
The parent of a 6-year-old child arrives at a clinic because the child has been experiencing itchy, red, swollen eyes. The nurse notes that the symptoms reported are affecting both eyes and purulent discharge is noted. Based on these clinical findings, what would the nurse suspect of the likely diagnosis? I'm hearing 3 a lot. 3 sound good to everybody else?
Probably started off as 4, but now it's 3.
Okay.
The purulent and is bilateral in there? Is that-
Bilateral is in there somewhere.
That's what gave it away.
Okay, good. Viral conjunctivitis, why not that one?
It's unilateral and it's watery.
Unilateral and watery for your viral conjunctivitis, alright? Chlamydial conjunctivitis is the same thing as a viral conjunctivitis, right?
Yes.
So that knocks 2 of them out already. Did I mention anything about any type of allergen or the symptoms going away?
No.
No, I did not, so we can probably knock that one out as well. So then everything left is bacterial conjunctivitis. We also saw bilateral, some nasty drainage in there somewhere, purulent discharge was noted. Everybody understand how we got to 3? Yes.
Sorry.
Don't open that Sprite. Let's go to our other ear, nose, and throat type infection. We're gonna talk about otitis media, which is also known as just a common ear infection. That's what you're gonna hear it most often called. When we're talking about otitis media, we're really talking about the infection within that middle ear. The next slide, I've got a good picture that's gonna show where our infection is really sitting at. It's usually due to some type of excess of fluid, some kind of bacterial buildup behind the tympanic membrane, down in that eustachian tubes that connect right there. You gotta have those bony structures as well that we don't hear. So like the malleus, the incus, the stapes, y'all remember those from anatomy? Yes. All right. Otitis media is most common in your younger population, your children. Why? Because their eustachian tubes are a lot shorter, they're a lot wider. So we can have an increased buildup just because of their anatomy. Once we get a little bit older, our eustachian tubes kind of lengthen out a little bit, they straighten out a little bit, get a little bit smaller, and then so we're not as at risk for otitis media or developing an infection. Our acute's gonna be 3 weeks or less versus our chronic, so we just have repeated episodes, constant episodes of getting an infection within the ear. We're starting having those symptoms. They go away after we treat it. A couple months go by, we get another one, and so on and so on. Alright. So we're really talking about the eustachian tubes. You're gonna come off right through here. Here's your bony structures of your middle ear. So again, you have that malleus that you can also see kind of behind that tympanic membrane, and then your incus and stapes. So all your fluid buildup is gonna be right in this vicinity, right behind that tympanic membrane. That's where we're talking about our infection for otitis media, our middle ear infection. So what can cause an otitis media infection? Our most common causes are gonna be from your Streptococcus pneumonia, that's gonna be one of our most common bacterial agents, your H. influenza, and then your Moraxella catarrhalis as well. It's gonna be your 3 main types. Once we have that fluid building up, backing up within our tympanic membrane, that's just going to harbor bacteria. It's gonna be a good place for that bacteria to grow and kind of have that overgrowth. And that's why I mentioned your biofilm in that area. We can also contribute it to secondhand smoking, some other environmental factors, some pollutants in the air. Improper feeding with the infants. So we're not sitting them up real nice and tall to feed, we're letting them lay on their back to take a bottle. And kind of that aspiration risk aspect of it can kind of add to risk for infection. What are we going to see, or what of our patients are going to complain of? So they're really going to complain about that ear pain. Everybody, I'm sure, has had an ear infection at some point in their life. If you haven't, you've gotten real lucky. But we're also going to have that fullness, that pressure behind that ear. Kind of like you had a sinus infection and everything stopped up. You're going to feel that pressure within that middle ear, which can lead to a little bit of conductive hearing loss, not being able to hear appropriately. Tinnitus, what's that?
Ringing.
Ringing in the ear. All right, so with the ringing in the ear, our conductive hearing loss, that fullness and that pressure, that's going to cause us to feel a little bit dizzy, have a little bit of vertigo. So we may be off balance for a little while until we clear this infection up. What are we actually going to see on our exam? So when we visualize that ear, what are we actually going to see? So we're going to see some redness, some erythema. We're going to see a little bit of bulging within that eardrum. We may see a little bit of fluid behind that ear. So you'll see a little bit of pocket of fluid. Maybe they have a perforated eardrum altogether, and so we will see that on our exam. We don't have that nice pearly gray eardrum like that we should. We have a loss of landmarks. Does anybody remember from assessment those landmarks, that cone of light reflex? Remember that? Remember where it's supposed to be on the right ear?
Nope.
That was a long time ago, right? First week of class, first couple weeks of class. So that right ear is supposed to be in that 5 o'clock position. Does that sound right? Sounds right. Left ear, about that 7 o'clock position. So this is what I'm talking about. So light reflex, this is gonna be your right ear. You see that 5 o'clock, we're gonna actually lose that. So when we're looking in that when we're looking in that ear, we're not gonna see that cone of light as well, or may not see it at all. We're also gonna not see that malleus, that little bony prominence. You see on the right side, we have that fluid backed up. We have that pus formation in there. And so now we're starting to see that bulging tympanic membrane, that bulging eardrum. It's red, a little bit of swelling in there. This slide right here is a great slide, just a couple different types of severity as well. If you look in the top left one right over here, can everybody see that kind of fluid bubble forming? That's what I'm saying when I say the fluid behind that ear. That's what we're talking about. I have a nice bulging tympanic membrane right here. It's real swollen. And this one is the perforated one. We don't see it at all. We can actually kind of see past it and see some of the bony structures of that middle ear. So that's a pretty serious ear infection right there. You can even develop some permanent hearing loss from that as well. So how are we going to treat our otitis media? A couple of non-surgical options. We're going to start off with some systemic antibiotics. We've got amoxicillin, and then we have also amoxicillin clonidinate, or Augmentin for short. We can do some warm compresses. We can put, even if you don't have a warm compress, you can tell your patients to put a wash rag on the hot water or put it in the microwave for just a minute and warm that washcloth up and then put it directly on their ear. They don't have to go out and get all those fancy compresses. My grandmother always used to say to blow cigar smoke in the ear. Yes, in theory, that is a warm compress, but I'm also breathing in cigar smoke, so don't do that. Anyway, some type of analgesic. So what's an example of an analgesic? Tylenol is a good one. What else? Aleve. Ibuprofen's a good one, so it can help have a fever reducer aspect of it and can also help reduce some inflammation. Which side are we going to lay our patients on? Like the little infants, What's a good side that we can put them on? Yes, we're gonna put them some pine to help with SIDS, but what about to help with drainage? Affected side down while they're awake. That's good. So we allow for some of that drainage to come out. On the other side, we have the surgical fixes here. Meningeotomy. Anybody know what that is? Ear tubes, close. That's the next one. So we're gonna make a small incision within the eardrum to have that immediate relief of pressure, to relieve some of that excess fluid buildup in the back. Allow that to drain for a little while, and the eardrum should actually just close up on its own, have a little bit of scar tissue, and it's pretty minimally invasive. So just a small incision with that eardrum, that's how we're gonna take care of that. Or we have what's called your ear tubes, your polyethylene tubes, pretty common as well, and that can be another option for our treatments. And that's what this slide's about. So we see on the left, we have allowed to build up excess of fluid, and then we have that bulging tympanic membrane. Then we can go in and make a small incision and actually insert one of these little tiny polyethylene little plastic tubes and encourage drainage to come out. We can actually leave these in for months and months at a time if they have these recurrent ear infections. Just to allow any excess fluid whatsoever, if they have it build up, that it can actually drain out. And eventually it'll kind of fall out on its own. Another example, and that's actually a real ear that you can see with the ear tubes in there. So if you actually look at your patient, you do a good assessment, and you look in your ears and you actually see that, don't get alarmed. You have an ear tube or a polyethylene tube. Alright, so this is gonna be our first boxes. Box 40.4, page 1012. Are gonna be some of your post-operative instructions. If they've had a meningeotomy or if they've had ear tubes placed, it's gonna be some good education points, post-operative education points. We also have box 40.5, and that's gonna be more of your preventative type stuff for otitis media. It's also on page 1012 as well. They're really one after another, so if you just look a little bit further down, you should see both of them all on one page. But what are some good things that I could teach my patient that has otitis media or has had a post-operative procedure, they've had some type of procedure on their ear? What can I tell them? Don't stick anything in there, like what, car keys or Q-tips,
Yeah.
little things that y'all hold your hair back with,
Bobby pin.
bobby pins, yeah.
Them things get the job done.
They do get the job done very well, but we're not telling our patients to stick bobby pins in their ears.
Is it water guys do?
Water is real bad for it as well, that's good, we wanna keep it as nice and dry as possible. So we're not gonna irrigate the ear at all, we're gonna, that's gonna actually increase some inflammation. What about if they go swimming?
The water.
Earplugs, so, we have ear protection, there's some type of earplugs that are more, protective for swimming. Or we can just encourage them not to swim like within the lake or in the pool, for an extended period of time. If that's an option, you need to try to avoid it. Or even just in the shower, we're gonna let the water just constantly run into our ear. Now, I don't know why you would just let water run into your ear, but, not gonna do anything like that. What about food? Does food matter with otitis media?
I want soft food.
Soft foods, why?
It might hurt.
Might hurt.
Your jaw.
So we're chewing, right? So, if we're eating on some real tough, something we have to really break down and really chew nice and hard, if we're clamping down on our teeth, that causes a lot of pressure on that jawbone, right? And causes a lot of pressure within that ear. So maybe we need to encourage a soft diet for a while. A lot of applesauce, that's great for me. A lot of Jell-O, maybe mashed potatoes or grits, things like that. What about when we sneeze? don't hold it in. I'm words worst at holding my sneezes in. I don't like to spew everything everywhere, so I usually hold it in. Try to encourage them to sneeze and let it out. Have their mouth open when they sneeze. And also just don't bear down. So when you're having a bowel movement or any other reason that you would kind of just bear down and kind of clench your teeth. We don't want that excess pressure within our ears. As far as prevention goes, we're trying not to expose them to the elements. If there's a lot of cold, windy type days, maybe put some earmuffs on, put little cotton balls in their ears, especially right after post-op surgery. Constantly monitor, make sure their ears are clean. We can wipe them out best we can with like a washcloth. Again, we're not trying to stick something down deep into the ear. Also with swimming, make sure the water comes back out of the ear. You know, when your ears get stopped up with all that water and stuff, make sure the water comes back out. We don't have just continuous wet area, because that's gonna be big to harbor bacteria. As far as pain management goes, we can do something like ibuprofen, Tylenol, just to kind of help manage some of that pain. Child has been diagnosed with an acute otitis media of the right ear. Which interventions would the nurse include in the plan of care? So select all that apply. Provide a soft diet. Does that make sense?
Yes.
All right, that's a good one for me. Position the child on the left side.
No,
Why not?
because you want them around.
The infection's on the right side, right? Okay, good. Administer an antihistamine twice daily.
That doesn't, no.
Doesn't really matter. We don't really need an antihistamine currently. Irrigate the right ear with normal saline every 8 hours.
No.
No, good. Administer ibuprofen for fever every 4 hours as prescribed and as needed.
Yes.
Makes sense, right? It's good analgesic, also help reduce that fever. Instruct the parents about the need to administer the prescribed antibiotics for the full course of therapy.
Yes.
If it always says full course of therapy, 9 times out of 10, that's a pretty good answer to choose from. Provide a soft diet, administer ibuprofen, and then full course of therapy of antibiotics. Make sense, people? Everybody good on that?
Yes.
Okay. Another question. Doctor prescribes amoxicillin for a 6-year-old child weighing 45 pounds, newly diagnosed with otitis media. The recommended dosage is 25 milligrams per kilogram per day, divided into 3 doses per day. How much amoxicillin should a child receive per day? And then we also have per dose. Give me just a second. Anybody got anything?
511 milligrams a day.
511 milligrams a day, I like that.
170 milligrams per day.
170 milligrams per dose. So 511 milligrams per day, and then 170 milligrams per dose. Do we need to work through that? Everybody got that?
Yeah.
Everybody's good? How many kilograms is that? That's probably a important answer too.
20.45.
20.45, all right, perfect. All right, let's move on to our respiratory type infections. There's 3 ones that we're gonna cover within this lecture itself. Let's talk about influenza, more commonly known as flu. And so it's just a very highly contagious viral respiratory infection. There can be a lot of different strains, and so that's why we hear flu A, flu B, flu C. That's why we're going to hear it. So it's different types of pathogens that can infect us. That's how we get these different types of strains, and that's what we'll get. Nice big slide. There's a lot of signs and symptoms, but they're very generalized as well. Influenza, it's pretty common, so most people should know your signs and symptoms. You got your headaches, your muscle aches, just some fatigue, sore throat, cough, nasal discharge. We can have one or two of these types of symptoms, but we can also have all of these at one time. Flu B is really common. You can also have some nausea, some vomiting, some diarrhea, so more of that GI upset compared to the rest of them where it's more of a respiratory, ear, nose, and throat type of symptoms. So how are we gonna treat our influenza?
Just
Sorry?
gonna treat the symptoms.
Treat the symptoms, okay? That's a good one. Good bullet point right here. The last one, must be taken within 24 to 48 hours after symptom presentation to be effective. So if we're gonna do any kind of treatment at all, any kind of antiviral at all, it needs to be within 24 to 48 hours after symptom presentation. That can be real hard because a lot of times we're gonna ride out these types of infections. Oh, I just got a common cold, 3-4 days go by, man, I'm not getting any better, I'm actually getting worse. I feel like a truck has ran over me, I just feel tired, I just don't feel right. And then I go to the doctor and I want something for it, but at that point it's too late. And that's where a lot of your patients kind of get angry at you, but it's been too late. So if we are gonna treat it and we are in that time frame or in that window of time, we're gonna use some antivirals. Your most common one is your oseltamivir. That's gonna be your Tamiflu. Now I got two other ones listed for you there. A viral illness will not respond to antibiotic therapy. Keep that in the back of your mind. I'm gonna highlight it in red as well. We're not giving antibiotics for antiviral type stuff. What kind of symptomatic management could we teach our patients about? So for sore throats, what could we do for that?
Cough drops.
Cough drops, that could be a good thing.
Hot toddy.
Warm tea, that's kind of gross, but okay.
Over-the-counter anesthetic spray.
Yeah, we have a chloroseptic spray. Facial gross, but it works really well, right? Saline gargles, we can do that. Just warm gargle rinses. What about for like the sinus type congestion?
Nasal spray.
We do nasal spray, we do Mucinex, those antihistamine type things. What about dehydration? That's a key one.
Water.
So we're gonna increase the fluid intake. Sprite, I don't. Gatorade, Pedialyte.
Isn't it 7-Up or ginger ale?
I don't drink the young because it makes me think I'm sick, so I just avoid them all. I usually go for water, Gatorade type stuff. But we're gonna increase that fluid intake as the patient tolerates it. What do I mean by that? So what if they have congestive heart failure? Do I really need to overload them with fluids?
Or kidney failure, don't
Or
get.
kidney failure patients. So we're telling our dialysis patient to drink a bunch of fluid and then they go see Amber over there.
And Amber's not happy.
And Amber's not happy because they're way overweight and they need a lot of dialysis because all that excess fluid buildup. So tolerating fluids as their condition allows. So if they have any other comorbidities, can they get that increased fluid? Really gonna encourage vaccination promotion. Whatever your view is on vaccinations, that's fine. But we're really gonna try to encourage vaccinations. So 6 months or older, especially in the immunocompromised populations, we're really going to try to encourage them to get these vaccinations so they have the best defense possible for influenza. So for instance, my brother that was here the other week, he definitely gets his vaccination every single year because he's immunocompromised and he's respiratory compromised as well. So it's kind of a double whammy. If he gets the flu, it would really take him out. I say that, he had COVID-19, he's the best out of all of us. So. But anyway, so 6 months or older, And then they can have even a more potent form or increased dosage of the vaccine for 65 and older, so it really protects them as well. We already talked about our symptomatic management, so those saline gargles, increased fluids, cough drops, some decongestants as tolerated. Reduce the spread. How are we going to reduce the spread of influenza?
Hand washing.
Hand washing, good. What else?
Stay home.
Lysol.
Lysol, all right. Stay home. Wear a mask. Probably avoid large crowds, right? So we're not infecting everybody again. And then we're gonna educate them on that medication management as well. That big key there, that 24 to 48 hours after presentation, that's when they can get those antivirals. They can get that Tamiflu that they see on TV all the time. After that, not really longer effective. We're going to encourage them again to take it for the full course of therapy. We're not going to allow them to stop their antiviral halfway through after they start to feel a little bit better. They feel great at that point, but I don't need that anymore. Really encourage them to take it for the full course of therapy. Another question for you. Client who has been experiencing fever, headache, and muscle pain for 5 days calls the primary healthcare provider to request a prescription for oseltamivir. Which information will the nurse provide? Healthcare provider will need to see you to order that medication.
Yeah.
You will need an influenza test in order to receive that medication. Oseltamivir is effective only when started within 2 days of symptom onset, or a flu shot would be better to reduce the severity of the symptoms. C, good. Yes, A and B are correct, but what's the most correct?
In 2 days.
So she's already day 5. There's no point in the physician seeing her, correct? To get this medication.
Give them a good antibiotic. That's what they always do.
Same thing with B. If she's having these symptoms, yes, she may have the flu, but it will eventually self-limit and it'll actually kind of cure itself. And so there's no reason to test her. Probably not. Some other education we could also tell our patients. What if our symptoms progress? What could it progress to? Pneumonia. Good. And so we need to talk about the signs and symptoms of pneumonia. And we're actually going to talk about pneumonia here in just a minute. Pneumonia. Infection in the lung space, and it's going to cause a lot of severe inflammation, a lot of increased swelling, especially within the alveolar sacs of our lungs, down deep within our lungs. That's where we're going to see a lot of that inflammation. We can also see some inflammation in the bronchioles as well, and it's going to have just a lot of increased production of secretions, these thick, nasty drainage, thick, nasty sputum. That's what we're going to see. With pneumonia, we're going to see impaired gas exchange, and that's the big one that we're going to be most fearful for, the one that we're going to look out for the most, the one that we're going to assess for the most. When we're talking of pneumonia, we have 3 different classifications. This is a pretty good slide as well. So for community-acquired pneumonia, what does that represent for us? It's in the name.
Community.
So we develop pneumonia within the community, somehow, some way. So we just talked about one, influenza or the flu. So maybe they had a flu type infection, influenza type infection that progressed, they got worse, and then they developed pneumonia from that. What else? COVID, that's a great one. Anything else? Really just any kind of upper respiratory illness, maybe a bronchitis, some lower type respiratory illness. Strep throat, it could potentially. Maybe COPD, an exacerbation of COPD. We're not getting those thick secretions out. And then we develop pneumonia from it. So anything really outside world that we can catch. That's how you're gonna classify a community-acquired pneumonia. Step further is your classification 2 here, your hospital-acquired pneumonia. This is after admission greater than 48 hours. So not as soon as you walk into the hospital and then I get pneumonia. That's not hospital-acquired. How can we differentiate that from community-acquired versus hospital-acquired? How do I know that they didn't get the infection that developed pneumonia before they come to the hospital? So we can test, but that's why I'm saying greater than 48 hours. That's how we're going to classify that hospital-acquired pneumonia. So anything 2 days after admission. And that could be from a list of things. Maybe they did catch the flu within a hospital setting. Maybe we didn't do great oral care like we should and brushed our patients' teeth. And then that infection traveled further south, got into our lungs, so we developed pneumonia from that. Maybe they did catch COVID-19 from the nurse who didn't do proper PPE when she went into her COVID-19 room, and then she didn't do proper hygiene when she left that room. Then we have our third class here, our ventilator-associated class. I'm not gonna spend a whole lot of time on that because we're not gonna talk about ventilators within this class, but in the fall, you'll hear it a lot. So your ventilator-associated type pneumonia, that's gonna be 48 hours after they are intubated. They're placed on the ventilator, they have an endotracheal tube inserted. That's gonna be your ventilator-associated pneumonia. So 48 hours after intubation. So what are our pneumonia patients gonna look like? We're gonna have an excess production of fluid and thick exudate type sputum. We're gonna have the greens, the yellows, the browns. Might see a little blood tinge in there as well. We're gonna have a little bit of chest tightness, maybe some type of chest pain, real productive cough. You're really gonna be able to hear it. Sometimes you may even hear their lung sounds before you even walk into the room. You can hear it from the door. What are their lung sounds gonna sound like? Crackles, I like it. Hoarse crackles, we're gonna hear that, and we're actually gonna listen to it here in just a second as well. But then they're also at risk for respiratory distress, and that's their biggest one. That's why I hide it in red. So they're gonna develop respiratory acidosis. Does that make sense for our pneumonia?
Yes.
All right, they're in respiratory distress, they're gonna develop respiratory acidosis. They're having a tough time getting that gas exchange, getting that oxygenation into their lungs and exhaling that CO2. So with respiratory acidosis, our pH is what? Low, so below what?
7.3.
7.35, all right. Our CO2 is what?
High.
High, so above what?
45.
45, good. What about our bicarb?
It shouldn't.
Doesn't matter, maybe change and maybe just the same, maybe in that 22 to 26 range. Y'all are gonna get sick and tired about ABGs because we're gonna talk about them all the time, but in the fall, you're really gonna get tested on again, so just keep it in the back of your mind. Why are they having issues with that gas exchange itself? Because of the alveoli. They're stiffened, they're inflamed, and that is what's allowing on that cellular level for that oxidation and CO2 exchange. So when our alveoli are not allowed to expand fully, they're stiff, they're hardened, they're not really moving at all. I can't get that good, deeper breath of air to fully open those alveoli, to fully open those lungs and allow for that gas exchange to occur. Let's listen to some lung sounds. Is that enough, everybody? Oh, hold on. I'm supposed to
Crackles
cough.
are ridiculous.
Crackles are what?
Cough, Armageddon.
Congratulations!
I was like, are we doing infection practice of like what buffets, cross-contaminated?
No, we're
No.
celebrating your
We're celebrating
doctorate.
you.
And everybody's just been weird, cause like Beth was like, what's your favorite drink? And like, Sam's like, what kind of
I didn't
snacks you
even
like? And everything's been weird today. People are like, you're coming to class tonight, right? I'm like, no, I'm not teaching, so, anyway, well, thank you. At nighttime when you're here, your family, so.